and I've sort of adjusted it slightly so that we kind of focus on the take-home points. And my objective of this talk is, because I reckon with coagulation, you look at this like kind of mess of Roman numerals on the page with arrows going everywhere, and it's really overwhelming. But what I want you guys to get out of this talk is to have a really nice kind of feel of how coagulation works, not necessarily with knowledge of all the Roman numerals and stuff, but just how a clot forms and how that's clinically relevant to us, with sort of impact from comorbidities and stuff which might impact the coagulation system. Can everyone hear me all right over all the birds?
Yeah.
Yes.
Okay.
Yes.
Awesome. Okay, I'm going to share my screen, hopefully. Oh, sorry. Give me a sec. I need a tech quiz to do all this stuff for me. Okay, there we go. No, that's not it.
Have you got dual screens, Anna?
No, not yet. Coming.
It's a good idea. They make the sharing a lot easier.
Oh, the two screens together?
Yeah, in the sense that you can put your PowerPoint on one of them, on the other one, like, and then when you share it, it gives you all these options, but it gives you the option of this screen or that screen, or you can actually share the PowerPoint. Well, that's it. We've got it.
You got it?
Yep.
Okay, amazing. Yeah, no, I definitely need to sort that out, because in this like Zoom forum, you can't share your screen and see your notes. And particularly in like topics where I need a little bit of reminding, it can be really tricky to remember what I wanted to say with different slides. So I need a second screen, but I'm not quite that organized yet, Jeff. One day I'll get there. Okay, so my background in coagulation is obviously it's part of the core sort of subject area that we have to study for medicine, but I did a master's honours and then a master's and then halfway through a PhD on coagulation in dogs and the impact that diseases like IMHA, pheochromocytoma and Cushing's have on clotting. We developed a test which is kind of this move away from testing components of the coagulation system like PT and APTT, and more testing like how a clot forms as a whole, because we know now there's so many different components to clot formation that being deficient in one may not actually predispose to bleeding. And we're now getting more and more interested in hypercoagulabilities, increased clot formation and risk of PTE and stroke. So these whole blood or like global clotting assays are becoming more popular. So the test that we formed was essentially putting plasma with all the clotting factors and stuff from an animal into a clear well, and then adding something to trigger the clot to form, and then we'd shine a light through the well, and as a clot forms, less light goes through. So we then measure kind of the light received on the other side. So as a clot forms, less light goes through, less light goes through, less light goes through. And then as the clot breaks down, more and more light comes through again. So we can actually get this really nice curve of how much, how fast a clot is forming and how quickly it's breaking down and how big that, or how dense that clot was. So it gave me a really nice feel for just how clots form, and you kind of just, you can extrapolate from that and put it into the patients that you're treating, which I found really helpful. So hopefully I'm using some of the graphs that we generated as part of that research in this talk. So hopefully you'll get the same kind of really nice feel of how clotting works. Oops. Okay, so I've pitched this as kind of exam questions, just so you guys can have a think about what you might get in membership exams. So the first question is compare and contrast the cell-based model and the cascade models of coagulation. This is not a question you're going to get at a membership level, but you might get components of it. So the next bit of the talk is really in depth. We're going to go into what the cascade model is and what its limitations are. So why we needed to change our thinking on coagulation. We're going to go into what the cell-based model is. And I've written here relevance to surgeons, but it's actually relevance to all clinicians who are performing any kind of invasive procedures, and that includes intravascular catheterization. So anything that's going to disrupt the tissue barriers. So first things first, this is a familiar model of coagulation. Does everybody remember this from uni, trying to remember all the Roman numerals and not really knowing which one was important and which one wasn't?
Yes.
Yep.
Hey,
Definitely.
Definitely. So we've got the extrinsic pathway and the intrinsic pathway. And then we've got the common pathway. So the pathway that everything goes through to form a clot. So this is really confusing, overwhelming, but the main things I want you to get out of this are that the objective is to produce fibrin, and you can't produce fibrin without thrombin. So let's forget about fibrin and just talk about thrombin, essentially, because thrombin will lead to fibrin. So then the only other sort of important part is that these two will lead to thrombin generation. So I don't need you to remember the numbers there. So moving on to the extrinsic pathway. Does anybody know why it's called the extrinsic pathway?
To do with like external damages to like blood vessels.
Exactly. Yeah. Yep. So tissue factor is called tissue factor because it's not in circulation. It's only in tissues. So the extrinsic pathway of coagulation is the pathway where tissue damage occurs, and that's the trigger for the clot formation. I hadn't really made that connection that tissue factor is only in tissue, it's not in circulation. And that's really important because obviously if you had all of the ingredients, the clot formation just in circulation, you could get systemic activation of coagulation all the time, but we don't. Coagulation is localized to the site of a tissue injury. How does that happen? It's because tissue factor is only in tissue, and all of those circulating factors stick to it as they go past. So that provides that localization for clotting to occur. Do you know how we measure this? Which test? PT, good, excellent. Do we know, so say we had a rodenticide toxicity, which factor is deficient first and therefore which test is prolonged first?
7.
7.
Yep.
7's the shortest one, isn't it?
Yeah, exactly. So 7's got the shortest half-life. So do you remember which factors become deficient with rodenticide toxicity?
The vitamin K ones, 2, 7, 9, 10.
Good. So we've got 2 down here. So we're going to get both PT and APTT prolonged if we're deficient in that. We've got 7 up here. So just PT prolonged, and that's first. So PT is going to get prolonged first. And then we've got 9 and 10, again in the common pathway.
Yeah.
So
same as the TV stations.
Exactly, yeah. I always said that, Jeff, and now everyone's like, Netflix.
I know, it's redundant now, isn't it?
Yeah, what's 2, 7, 9 and 10? Nobody's got those little knobs that you twist on your TV to get the channels anymore. Good, so that's that extrinsic pathway. And then the intrinsic pathway is kind of just the rest of the factors. So I don't want you to remember any of these numbers really, but I guess importantly, the APTT is the test that will test for deficiencies in these factors. And we can have really significant hypocoagulability. So for example, haemophilia is deficiency in either factor 9 or 8, and we get really severe hemorrhage as a result of haemophilia, despite there theoretically being an alternate pathway for clots to form. So I didn't really go into this, but I'm just going to see if I can get my notes up somewhere else. So the flaws with this model, can anyone think of any reasons why we needed to sort of update our thinking on this? That's a really vague question, but I've sort of alluded to it just then. But essentially it implies that if there's one factor missing here, that's fine. This pathway will take over and we'll get significant clot formation. And likewise, one factor missing here, that's fine. We'll still get significant clot formation because there's an alternate pathway to stimulating clot formation. And we just know that clinically that's not true, and it's not representative of what animals are capable of. It also, this pathway kind of implies that factor 12 is just as important in coagulation as factor 8, when in reality, if you're deficient in factor 12, you're actually more prone to clot formation, so hypercoagulable, as opposed to deficiency in factor 8, where you'll have catastrophic bleeding. So this model just doesn't really tell us how important the different factors are. And it also then implies that we don't fully understand how clotting is occurring if we're using this model to model how clots are forming. And the other thing is that it does sort of assume that if tissue factor is not involved, that clotting can be activated and perpetuated just generally in circulation, so that clotting is systemic rather than fixed. And the vast majority of the time, clotting is fixed. And that's really important, obviously, so we don't end up in situations like DIC. So if we then say, okay, the cascade model's got some flaws, let's try and look at a model of clotting where we're looking at what's actually happening in the body and where we're getting this interaction between all of these factors in the cascade model. But then we've also got platelets, and we've also got von Willebrand's factor, and we've also got vessel walls and all of that stuff coming into it. So the cell-based model, instead of looking at the components of clotting individually, looks at the phases of clot formation. So it's divided into 3 phases. The initiation phase, so what actually triggers the need for a clot. We look at an amplification phase where all of the ingredients for significant clot formation are built, essentially. And then we look at the propagation phase where we get huge amounts of thrombin being developed. Thrombin then obviously leading to fibrin and leading to a clot. So I'm going to go through this in phases, and I'm going to repeat myself a few times because this is really complicated. So essentially, the initiation phase is where a clot is being triggered. So the initiation phase in the cell-based model is equal to the extrinsic pathway in the cascade model. So I've put the extrinsic pathway here. So tissue factor is exposed. So vascular injury leads to the exposure of tissue factor. Tissue factor is stuck at the site of the injury, right? It's in the actual cells that are injured. So circulating factor 7 here goes past and sticks to the tissue factor. So that localizes that initiation of clotting at the site of the injury. That binding of 7 to tissue factor activates factor 7, which can then activate factor 10, which is moving past, and 9 to a lesser extent. So once we've got activated factor 10, circulating factor 5 comes past and sticks to factor 10. And then we get this little bit of thrombin being generated. So we've got a tiny bit of thrombin being generated at the site of the injury where the clotting factors have just stacked up on top of each other. And that's where the initiation occurs. So thrombin being the objective to generate fibrin. So we're going to do that in a visual format, just to change the way our brain's thinking about it. So we've got an injured vessel wall This is an endothelial cell, which has got tissue factor exposed on its surface now, where previously it had been inside the cell. Circulating factor 7 is going to bind to the tissue factor and be converted into factor 7A. That factor 7A is going to catch factor 10 and factor 9, which is going to generate small amounts of thrombin. So prothrombin into thrombin. Is that all right, everybody?
Yeah.
So initiation of, we've got initiation of clot formation via that extrinsic pathway, with tissue factor being the thing that really started I'm going to go back, sorry, that started the clot forming. So I like to think of coagulation as similar to building a fire, and you can have anything from like a little flare, like striking a match, to a raging bonfire that you're continually pouring accelerant onto, as far as kind of the spectrum of fires go. We're trying to start like a nice little backyard campfire. We're not trying to start a bonfire. We're not trying to strike a match and then have it go out before the fire started. So if we look at which sort of parts of coagulation coincide with what type of fire, this initiation phase is like striking a match. So we're going to get this burst of thrombin generation, but it's going to be really short-lived unless it leads to something else. So the amount of thrombin produced is not enough to produce a significant clot. We need more to happen after that. So we're trying to build a fire, we're going to strike a match. There's no point doing that unless we've got the ingredients for the rest of the fire there. So we move on from the initiation phase to the amplification phase. So those tiny amounts of thrombin that were produced, they've turned fibrinogen into fibrin, which is important, but we know it's not enough fibrin to actually make a clot. One of the most important roles that thrombin has is to activate all the other factors in the intrinsic pathway. And it doesn't matter what the numbers are. What you need to remember is that we've got extrinsic triggering or initiating coagulation, and then the thrombin from the extrinsic factor is going to go on and activate the intrinsic pathway. The other thing that thrombin does is activates platelets. It's a really potent platelet activator. And I put this electron micrograph picture of a platelet in because I find it so amazing. So these are round cells when they're not activated. And this is a true picture of an activated platelet. So you can see how this cell, which was round, has increased its surface area by over 100 times by extending these tendrils out from itself. And you can picture it. And this is what I want you to get out of today. I want you to picture what happens with coagulation. You can picture these platelets like an octopus grabbing on to the site of an injury and staying there. So that's where we get further sort of localization of clotting. That makes sense to everybody?
It does.
Yeah. So amplification, we've got thrombin, 3 different pathways, developing fibrin, activating the intrinsic pathway to perpetuate coagulation, and activating platelets to localize coagulation. So then the platelets do more than just grab on with their octopus tentacles. They actually externalize a phosphatidylserine, which is one of the phospholipids. Remember the little sperm-looking things on the surface of cells? So this little phospholipid normally lives inside the cells, and it flips to the outside when a platelet becomes activated. Phosphatidylserine is like glue for clotting factors. So once that's externalized, it provides this kind of, it's like a site that a factory is going to be built on. It provides cell membrane to localize coagulation at the site of an injury. The other thing that platelets do is degranulate. So they recruit and activate more platelets to the site of the injury, again, providing more surface area for clotting to occur on. And interestingly, and a little bit scarily, platelets snap off the end of these tentacles in little, we call them microparticles, so tiny little platelets. And they actually release those into circulation just to increase the amount of clotting factors being produced and increase the amount of surface area for clotting to occur on, but this is not localized. So you can see in this amplification phase, we've activated platelets and all of the knock-on effects of that. We've got small amounts of fibrin being produced, and we've got all of these other clotting factors primed and ready to go, which brings us to the propagation phase, where step 1 is that these clotting factors team up and form a factory. So we've got 9 and 8 there, 8 and 9. It's probably easier to remember if you do it in order. So factors 8 and 9 form this factory called 10As complex. If we remember what the suffix As means, it's what we use to describe enzymes. So it changes something to something else. And if it's a 10As complex, we're changing factor 10 to factor 10A. So this factory, made up of factors 8 and 9, is designed to produce huge amounts of factor 10A. So step 1 is the 10As complex forming. Now these factories are forming on the surface of those platelets. So that's why the factory site got cleared in when the phosphatidylserine went to the surface of the platelet. That's the factory site, and then this first factory gets produced on the platelet surface. Oops, I've missed a slide. Sorry, I've missed a slide. So the second thing, the step 2, is the prothrombinase complex being formed. So next to our 10As factory here, we've got factor 10A being produced in large amounts, which can then participate in the building of a second factory called the prothrombinase, the factory that changes prothrombin to thrombin. And that is made up of factor 10A and factor 5A. So we've got 2 factories produced, which has set up our ability to produce huge amounts of thrombin. So if you try and do this clotting, if you measure clotting without any cell surface in your sample, you get tiny amounts of thrombin. So if you don't have platelets or cell surfaces that can provide a factory site for these 2 factories to be built, you won't get significant coagulation. So it's not fair to just sort of do an APTT or a PT and measure the amounts of clotting factors you've got in circulation, because those clotting factors aren't going to produce significant clot if you don't have platelet surfaces. And we know that clinically, you know, if a dog's thrombocytopenic, they bleed catastrophically. And if a dog's deficient in one of the enzymes here, so factor 8A, they bleed really significantly. So these 4 clotting factors are much more important than any of the other ones in the rest of the pathway, because the amount of thrombin produced when they form these factories is 300,000 times more than without the factories. So it's a huge difference in the ability to produce thrombin. Is everyone following?
Yes.
Yeah.
It's
Yeah.
much
Right.
simpler when you put it that way than it was to follow the diagram in Ettinger.
I think so too. Yeah.
Even though it's I can see where you've sort of got the diagram from.
Yeah.
It's just your explanation just makes it so much easier.
All right. This is pretty heavy. Sorry about this. It's going to get lighter, I promise. So now what does that thrombin do? We know what it does. It produces fibrin and it produces a stable clot. So if we then look at that fire analogy we talked about, we've got tissue factor, or the extrinsic pathway, being those redhead matches. We've got the intrinsic factor being just a wet log. So the intrinsic pathway is not going to start a fire unless we've got some kindling and stuff in the mix. So we get activation of coagulation, producing small amounts of thrombin and lighting our dry kindling. And then that dry kindling is what helps to light the log. Does that make sense? So if you then get these complexes forming from activation from the thrombin, we're pouring a little bit of an accelerant on the fire. So we're really making that fire light. that all right, everybody?
What would the platelet be in this analogy?
Well, the platelet provides the surface for the complexes, so I reckon it goes in with the kerosene.
Okay.
Yeah. So platelets are interesting because they've got a role in the initial plugging as well. So they do the holding on at the beginning. So whilst they amplify clot formation, they also initiate it a little bit. So they've got a role in kind of all phases.
So they're like the rock around the fire.
Oh, I like it.
And keeping it all in.
Yeah. Well, they're like, yeah. But then they're accelerant as well. So you don't want your rocks catching on fire, but they will.
Multi-phase.
Platelets don't really fit into my analogy. Thanks for saying that. So just to put this in a different kind of way, like looking at clot formation, this is a graph that from the research I did. So we put the serum in at 0 minutes, plasma in, and we initiate clot formation at 0 minutes. And then we put the drawer into the machine, and then we measure how much light's getting through. So this is maximum light. And then as the light getting through drops off, it goes up to a maximum point. And then as the clot breaks down and more light gets through again, we go back down to 0. So if you look at the time frames here, we start at 0 minutes, and this is our initiation. So I've initiated clotting at 0 minutes. From 0 to around about 6 or 7 in normal dogs is the amplification phase. So I've initiated here, I've struck the match here, and then I've got all of these factories being built in this time, or all of the ingredients being activated in this time. And as soon as we get our factory built, you can see the amount of clot forming goes up exponentially. It happens really fast. So over the course of about 5 minutes, we get maximum clot formation. And then we turn a corner and start getting clot breakdown again. Now, obviously, this is dependent on the size of the injury. So I only struck 1 match here. If you've done a big surgery, you're striking a lot of matches, and we're going to get activation at a lot of points along this pathway. Clot's not going to break down if we've still got activation and triggering of coagulation. So this is, I just really like sort of seeing, okay, no minimal clot formation, and then all of a sudden a lot of clot forming, and then it breaks down again. I find it really helpful to just visualize that. The other important thing is the time frame in animals. So we're not going to get significant clot formation for at least 5 minutes. So when people say you have an injury, hold it off for 5 minutes, there's really good science behind that. Don't lift the swabs up. Look at your watch, make it 5 minutes, because you're not going to get significant clot formation before that. The other thing, sorry.
Older vets used to say 6 minutes, so it just shows you we were less impatient.
So true. So the other thing to think about is the clinical relevance of your APTT and PT assays, and how important it is to look at more components of clotting than just the factors. So you can't say that a dog has normal clotting capacity unless you've checked the platelets. So the other clinical relevance is that with platelet, you don't just get a loss of that initial sort of primary hemostasis or plugging of holes, you also get a loss of factory sites and therefore less thrombin produced. And the other thing, as clinicians, we're often causing vascular damage. We're putting in IV catheters, we're doing surgeries, we're doing invasive procedures like O-tubes and things like that for us medicine people. We're continually exposing tissue factor, and particularly in patients that are predisposed to increased clot formation or decreased clot formation, we're potentially going to be activating coagulation significantly. So now moving on to our next questions, I feel like we've sort of answered, compare the cascade versus the cell-based models of coagulation. So our next area of interest is increased clot formation, so hypercoagulability. So my first question for membership candidates is describe the natural mechanisms by which coagulation system avoids systemic activation of coagulation, or DIC. So what helps to localize coagulation to the site of injury? And we've talked about it already. Max, you've been very quiet. You're up.
I'm thinking about what you have talked just now. Isn't it the local anticoagulant substance like nitric oxide and?
Yep. So there's endogenous anticoagulants, which is a really important factor, and they're both in circulation. So the three main ones, protein C, protein S, and antithrombin, they're in circulation. And then there's the local factors like the vessel wall. You can't get a clot forming on a vessel wall that's not damaged. So when damage does occur, what helps to keep the clot at the site?
Is it where it's kind of down to the tissue factor? Like,
Yeah, absolutely.
so that we know that it's localized there?
So the tissue factor is on cells, and the circulating factors that have been activated stick to that tissue factor. They're not just sticking to each other in circulation. So we've got the localization by the site of the injury. So that's where the tissue factor's exposed. And then what happened in that amplification phase to platelets?
Degranulation? Or do you mean more the that part?
Yeah. So they stuck to the site of the injury. So they stuck to the thrombin that activated them. So we've got platelets keeping coagulation localized. We've got the circulating anticoagulants mopping up any systemic activation of coagulation. And we've got tissue factor keeping everything stuck in the same spot. So that what normally decreases your risk of systemic activation of coagulation or inappropriate activation of coagulation. So coagulation cannot be significantly activated without tissue damage and tissue factor exposure. We've got trivial amounts of thrombin only being produced without the platelets. So we can't get 10As and prothrombin A. So if we don't get platelet binding at the site of the injury or activated platelets at the site of an injury, we're not going to get significant thrombin. And then, like Max said, the endogenous anticoagulants, which will mop up any activated clotting in circulation. So next question is discuss the mechanism of hypercoagulability with particular reference to 3 predisposing conditions.
So endothelial damage, hypercoagulability, and this is the virtual triad.
Yeah, excellent.
Hypercoagulability, endothelial damage, stagnation.
Good, excellent, well done. So when we talk about hypercoagulability, it's actually a component of Virchow's triad. It's not all 3. So Virchow's triad is the predisposing factors for thrombus formation. And we know about vascular damage. We know how that activates coagulation. Stasis activates platelets and predisposes to clot formation. And hypercoagulability is this component here, which is an absolute rabbit warren. So that's what we're going to focus on with this question. So describe the mechanisms of hypercoagulability and how different conditions might predispose to clot formation. So there's 3 different ways how you might have increased clot formation. So you can have an increase in procoagulant factors. So they include all of the clotting factors that we've talked about, but also increased numbers of platelets and increased amounts of or long forms and von Willebrand's factor. So increased procoagulant factors. But then you can also get increased clot formation from decreased anticoagulant. So if you've got less of that kind of antagonizing anticoagulant in circulation, you're going to get, on balance, an increase in clot formation. And then the third mechanism is decreased clot breakdown. So you might have normal clot formation and normal balance of procoagulant factors and anticoagulants in circulation. But if you don't have fibrinolytic factors, that clot's going to stick around for a lot longer. And if it sticks around for 5 times as long, you've got 5 times the possibility of that going into circulation and causing an embolic event. So I think this is really important conceptually. Is that clear to everybody? Three mechanisms of hypercoagulability: increased clotting, decreased anticoagulant, or decreased clot breakdown. So if I would be an arsehole membership examiner. Sorry, everyone. So this would be a hard question, but they would be the 3 main points I'd want you to recognize if I asked a question about hypercoagulability. So this picture here, again, I like to see things just pictorially. So this is a dog with Cushing. So the blue line with green dots, I don't know why the dots make green, is a normal dog. So we can see that at that sort of 5-minute mark, we hit that propagation phase and we get really significant clot formation. So the amplitude of the clot, so the sort of density of the clot, we got up to 0.17 here. This is a dog with Cushing's, where the clot formed slightly sooner, only by a couple of minutes. The amount of clot formation was much higher, so the clot was double as dense, and we watched it for an hour, and it never fully broke down. So really delayed fibrinolysis in this dog with Cushing's, and in all dogs with Cushing's, in fact. So can you see that sort of pictorially, how we've got an increase in clot formation and then decreased clot breakdown? And if you've got clot present for that much longer and that much more clot present, then there's more risk of thromboembolic events. Does that make sense to everybody? Does everybody else find these graphs as pleasing as me?
Yes, I love visual representations.
Thanks. So the question said, discuss hypercoagulability with reference to 3 conditions. So I'm going to go through a few conditions that cause hypercoagulability, and there's way more than 3. But the one I think we deal with most commonly as clinicians is hyperadrenic corticism. So we talked about the factors of hypercoagulability being increased clotting factors. So in Cushing's, there's documented to be increased factor 7, increased 12, increased 9, increased 10, and increased 5. Now, of those, we know 5, 10, and 7 are very important in the formation of significant thrombin. So we're going to get increased thrombin generation and therefore increased fibrin due to increased clotting factors. In Cushing's, we've also got increased von Willebrand's factor. Now, von Willebrand's factor is actually another factor we haven't talked about, but it really helps to localize clotting. So von Willebrand's binds both factor 8, which is one of those very important ones. 8 and 9 make up the 10As complex. And it's like it comes out of the endothelial cells in these long chains and it waves around in the vessel. And when it's activated, it binds platelets on the way past. So if you've got increased von Willebrand's factor, it's like having spider webs across your vessels and your platelets get caught in there. So it increases von Willebrand's factor. And it also, how often do we see thrombocytosis in our Cushing's dogs? It's really common. So increased numbers of platelets, which are going to cause an increase in thrombin. So we've got increases in factors, increases in platelets, von Willebrand's, and we've got decreases in antithrombin. So decreases in our circulating anticoagulants, all of which are going to increase clot formation. Now, interestingly, in humans, and this is not documented in dogs, or there's like a preliminary study which suggests it, but it's not been investigated extensively. Plasminogen activation inhibitor 1 is increased. So this is like the ultimate double negative for me. I find it really hard to comprehend. Plasminogen breaks down fibrin. So if you inhibit activation of plasminogen, you're going to get fibrin sticking around for longer. So decreased fibrinolysis. Make sense? Is everyone following? I can't see your faces. Yes? Okay, good. So we've got the triple threat with Cushing's. We've got increased clotting factors, decreased circulating anticoagulants, and decreased fibrinolysis. So then looking at cardiac disease as the next factor next disease to consider for hypercoagulability. The mechanisms that cardiac disease will cause hypercoagulability: turbulence. So if you've got degenerative mitral valve disease and a big regurgitant jet, which is banging on the endocardium of the atria, you're going to get platelet activation within that atria. And then those platelets are activated due to turbulence, but they're not localized. So they're not actually sticking anywhere. So they then go off into circulation and provide more surface area and activate more platelets by the process of degranulation and microparticle formation. We also have endothelial and endocardial damage. So those both on the valve themselves, which are often traumatized and damaged and vegetative. We get tissue factor being exposed, but also the regurgitant jet can be quite focal and cause endocardial damage in the atria, and that's going to expose tissue factor as well. So there you're going to get some localized clot formation. So the platelet activation results in thrombin generation, which is going to perpetuate coagulation, activate the other factors. And then we get some stasis as well, particularly in the auricles, so right and left auricles. If we've got left atrial or atrial enlargement, we get some stasis occurring as well, which is going to provide more opportunities for all of those activated clotting factors and platelets to form a clot in the atria. And this is obviously more common in cats, but certainly occurs in dogs. And in humans, one of the leading causes of stroke is an association with atriomegaly and stasis. So I will actually just point out here, I've written arterial versus venous. So clots that form in the arterial system are generally more dangerous. So if you've got a clot in the arterial system, it can go to the distal aorta or the brain and cause pretty catastrophic complications. Having said that, we see venous clots more often. So we see clots that go to the lungs and cause pretty significant pulmonary changes more often. Now, we typically think of clots that form in the arterial system as clots that are mostly platelets. So if you did histology on an arterial clot, like a stroke, they call them white clots because there's mostly platelets in there, as opposed to a venous clot, which is mostly made up of clotting factors and red cells. So venous clots, stasis is more of a issue. Arterial clots, platelet activation is more of an issue. And when we've got cardiac damage, we're usually dealing with the arterial system, aren't we? So clots forming in the atria are going to be arterial, but interestingly, stasis is a component as well. So where you've got stasis, you get clotting factor activation more than platelet activation. So clots that develop in cardiac disease aren't typical arterial clots in a lot of cases if stasis is one of the factors. So they might have venous component, and they might have clotting factor components to it more than just platelets. I've explained that so badly, sorry everyone. So they're a bit of a combination of platelet and factors, and that's just a consideration when we're looking at anticoagulating these guys. We want to potentially target both the factors being activated as well as the platelets being activated. So the third condition I wanted to talk about is protein losing nephropathy or enteropathy. And the mechanism that causes hypercoagulability is via the loss of the anticoagulants, circulating anticoagulants. And the one that's been documented most commonly has been the loss of antithrombin. It's a really small protein, so it's lost through the kidneys really early in the course of protein loss. And this is just a really interesting sort of pictorial view of the impact that has on clot formation in real time. So this is the normal dog. Remember, the clot, that propagation phase starts at about 5 to 6 minutes. In a dog with protein losing enteropathy, I couldn't get the sample into the machine fast enough to catch the beginning of the clot formation. So the clot was that propagation phase started way before it did in a normal dog. So that shows us what the impact of circulating anticoagulants has on delaying amplification and propagation of coagulation. So if you're missing those endogenous anticoagulants, there's no inhibition to the amplification and propagation of clot formation. We can also see that this dog had decreased clot breakdown. I think we've probably underestimated how big this dog's clot got because we haven't caught his baseline. So he might have come up from here, but we couldn't get the sample in the machine fast enough to catch the beginning of clot formation. Can everybody sort of picture that? How fast clots are forming in these dogs? Yeah. And then other causes that you could have mentioned in the answer to that question. Diabetes increases inflammation as the main mechanism, and also increases liver size and turbulence of blood flow through the liver. Any malignancy can be associated with inflammation, and also vascular damage, particularly things like hemangiosarcoma, where you get constant tissue factor exposure and platelet activation locally. And because it is endothelial disease, that's sort of in circulation. So there's a lot of procoagulant factors being released into circulation. Hyper and hypothyroidism both impact clotting. And we had a dog recently who had a TPLO who was hypothyroid, and the owners stopped the supplement over the sort of perioperative period. And this dog came back with huge volumes of hemorrhage, and restarting the thyroid supplement decreased the hemorrhage. May have been time as well, but certainly documented in humans to hypothyroidism increases bleeding. So not really hypercoagulability, but hypo. And then any immune-mediated or inflammatory diseases can also increase clot formation through a variety of mechanisms. So just a couple more examples of sort of how significantly diseases can affect clot formation. We've got the grey line being the normal dog. We've got a dog with IMHA, and you can see that propagation phase starts much earlier, so starting at around the 2-minute mark in that dog. And the amount of clot formed is significantly higher than in the normal dog. And then we've got a dog with a pheochromocytoma who had the tumour invading into the vessel, so significant vascular damage as well. And you can see that it was actually quite delayed in the start of that propagation phase relative to the normal dog, but the magnitude of clot formation is just huge. So we can only really speculate on that because we haven't measured all the different components of clotting going into that, but significantly more clot formation in these dogs.
The immune-mediated disease, Anna, thromboembolism is the cause of about 1/3 of the deaths.
Yeah.
I'm also wondering what effect the treatment has on that. Like, they're on fairly high doses of corticosteroids, which is in a sense creating a Cushing syndrome. And I'm wondering how much impact that has.
Yeah, absolutely. So by giving cortisone to these dogs, we're magnifying their hypercoagulability, and over time will decrease the inflammation and therefore improve things. And obviously that's what we have to do, but it's certainly a consideration, because not only are we going to get an increase in clot formation from the IMHA, so if we're already at 4 times the clot forming capacity of a normal dog with IMHA, and then we add cortisol onto that, and along with that cortisol, the decrease in clot breakdown ability. So we're going to get a huge increase in the number of clots formed, the size of the clot formed, the strength of the clots formed, but also those clots aren't going to break down very well. So we absolutely have to be addressing coagulation in like hypercoagulability in these dogs. So my last question, which leads on quite well to that, is how do we then choose anticoagulants? So my question, if I was a membership examiner, would be discuss your approach to prophylactic anticoagulant use in a dog with primary IMHA. Thank you, Jeff. Justifying your choices with reference to the mechanism of action of your chosen anticoagulant. So does anyone want to tackle that question? What would you choose, knowing what you know about coagulation now?
I'll have a crack.
Thank you, Josh.
Two things come to mind.
Yeah.
One would be, one that tackles kind of like a common pathway.
Mm-hmm.
Or like the kind of accelerant part of the kind of general cascade. So that, I think that would be like rivaroxaban.
Yeah, great.
The other one would be targeting platelet activity, and I think that would be clopidogrel.
Yeah.
And the third one I just thought of would be, I don't know if you could use things like IgIG in that as well to try and stop humping. I don't know if that is part of the answer, but that's the other one that kind of comes to mind.
Did you say IVIG?
Yes.
I don't know how it would, I mean, it would decrease the amount of inflammation, theoretically. But I don't know how it would directly anticoagulate.
Cool. Okay. I was just wondering if it, because in my mind, I think of it as stopping like more clumps forming. But anyway, yeah. So.
Oh, I see what you mean. So a really important differentiation between clots in circulation and aggregates in circulation is that aggregates are really weak bonds. So when they go through the capillary systems, they break down. So they just roll off each other and then they stick back together once they get into bigger vessels, as opposed to clots, which are more solid.
Okay.
So clots fibrin based, whereas aggregates are just the antibodies binding to the FC receptor on each other. And yeah, sticking the red cells together, essentially much weaker bonds than a clot. So IVI, that's a really good thought, but the bonds created or the bonds prevented by IVIG are much weaker than clots. Oops. Okay, so the questions you want to ask yourself when you're prescribing an anticoagulant is the biggest risk with this condition arterial or venous clots, which might change whether you're trying to inhibit platelets versus clotting factors. And we know now that it's all intermingled and it's not as kind of clear cut as that. But if I've got an increased risk of stroke, I'm going to go with a platelet inhibitor versus an increased risk of venous thromboemboli, I'm going to go with a clotting factor inhibitor. The other components of increased risk of thrombosis is stasis. So is the patient ambulatory or is stasis a factor? So does this IMHA patient have concurrent cardiac disease and we're dealing with some left atrial stasis? Or are they non-ambulatory and therefore more likely to get venous thrombosis from decreased skeletal muscle facilitating venous drainage? Are there any comorbidities? So do we have to consider cardiac disease and stasis or other factors? Do we have Cushing's disease, including prednisolone use, like Jeff identified, and therefore we're not only got an increased risk of arterial disease, but increased clotting factor activation associated with Cushing's, essentially? Is there any chance the patient's going to need surgery or an invasive procedure? So we had a dog recently with a arterial thromboembolus in its foot and was going to need an amputation. And we really wanted to start this dog on clopidogrel, but that would have made the surgical risk much higher. And we were bound to sort of starting an anticoagulant that we could reverse or that was going to clear the system more predictably in the preoperative period. So just for context there, factor inhibitors, some of them will be either partially or completely antagonized by protamine. So particularly unfractionated heparin, which is being used in critical care settings in centres that can monitor, like with the whole blood clotting capacity. They're using just heparin CRIs and titrating that to the dog's coagulation ability, and then you can actually reverse it going to surgery and then start it up again as soon as you're out of surgery. So it's quite a nice thing to have that ability to reverse it. And the other question is there a known deficiency of antithrombin? So are clots going to be forming really, really fast in this patient, and do we just need to hit them really, really hard to try and prevent clot formation with multiple anticoagulants? So generally speaking,
why do you prefer, prefer clopidogrel over aspirin?
So there's been a couple of studies comparing, particularly in cats with FATE, comparing the effect of aspirin and clopidogrel. And aspirin has very unpredictable effects on clotting. So at doses where we got predictable effects of clotting, we had very high incidence of gastric ulceration. So the side effects of aspirin are much higher. The predictability of clotting is much lower. So now the preference on the kind of consensus statements is clopidogrel. So generally speaking, we've got a choice of anticoagulants. They're either platelet inhibitors or factor inhibitors. Generally speaking, the platelet inhibitors are best for arterial clots, and the factor inhibitors are best for venous clots. And there's so much overlap there that's not kind of clear cut, but that's just the general thinking in the human world. Generally, as far as platelet inhibitors go, I'll always choose clopidogrel. I just think it's better tolerated than aspirin and more predictable effect. Whereas factor inhibitors, that's where I sort of will look at those underlying factors that we need to consider. So things like stasis, things like cardiac disease, things like needing surgery or being really nervous about causing bleeding in a dog. I'll sometimes use unfractionated heparin CRI, which I can then reverse if I'm really nervous about it and they're hospital patients in an ICU setting where we can monitor them. So the reason why it's so important to know if a patient is losing protein is if they've lost antithrombin, heparin won't work. So unfractionated heparin potentiates the action of antithrombin. So if you don't have antithrombin, the heparin doesn't work predictably. So you have to rely on one of these inhibitors of factor 10A instead, or a fractionated heparin.
And how do you reverse the heparin? Just stop giving it?
The heparin you can actually reverse with a medication called protamine, which decouples the heparin and the antithrombin. It partially reverses the effects of both clexane and fragmin, but incompletely, so it's not as reliable. And I don't know what effect it has on the rivaroxaban. But it's sort of just nice to have that safety net of being able to reverse it if you've got significant bleeding. So particularly in perioperative, like we do this in dogs with adrenalectomies and things like that, so really high clotting risk. We often use unfractionated heparin CRIs, and then if they've got significant strike through in the post-operative period or bleeding, we just reverse it. And that is the end, and we better actually wrap up because we've gone right up to 9 o'clock. If anybody does have any questions, please feel free to email me. We'll email out a copy of this video because obviously I've gone through a lot of information. So if anybody wants to revisit any of the images or anything like that, you can access the video. And
Oh, thank you so much.
pleasure.
Thanks, Anna. That was making those diagrams in Messenger much easier to understand.
Oh, good. Thanks. All right. Thanks, guys. See you soon.
All right, bye.
Bye.
Thanks, Anna.